Hello, everybody. I'm 𝔻𝕚𝕚𝕚𝕬𝕐, and on behalf of CCI, I'm really excited to have the next episode of our series in disparities in cardiovascular care this morning. Today, we will focus on the issues of sex differences in the treatment of ischemic coronary artery disease in women as compared to men, and specifically focus on the exciting arena of chronic total occlusions. And we have two manuscripts with distinguished authors who will be present today. And this issues of disparities in how we treat our patients is an important area that CCI is continuing to highlight. And I'm extremely excited to have Dr. Cotter here this morning from our social media team, who will be leading our discussion today. Dr. Cotter, thank you so much.
Thank you very much, Dr. 𝔻𝕚𝕚𝕚, for that introduction, and also to this diversity series of CCI cast. Today, we have a distinguished panel of authors, and we will be discussing two papers. The first of it is one on the impact of sex on outcomes of PCI for CTO, which is a meta-analysis. And we have the first and senior authors of that paper. We have Dr. Azka Latif from Baylor College of Medicine, Texas, USA, and Dr. Poonam Velgapudi from the University of Nebraska Medical Center in Omaha, Nebraska, also from the United States. The other paper we will be discussing, specific to sex differences in CTO-PCI, comes from the ER-CTO study, that is the European Registry of CTO, where they published gender differences in PCI for CTO from this registry. And we have the first author of that paper, Dr. Alexandre Avran, who is from Centre Hospitalier de Valenciennes in France. Welcome, everyone, and thank you very much for your time today.
Thank you.
So if we might start off with the discussion, firstly with the meta-analysis that was published in late 2021 in CCI. Dr. Latif, could you please summarize for us the results of this meta-analysis of first 14 observational studies looking at sex differences in CTO-PCI, please?
Thank you, Aisha, for having me here. So I'm going to be summarizing the results of our meta-analysis. We included a total of 14 observational studies, and 6 of them were multi-center and 8 were single-center studies. Our primary outcome was in-hospital all-cause mortality, as well as the mortality at the long term as well. The secondary outcomes included procedural success, as well as in-hospital MI and the MI at the longest follow-up, as well as the in-hospital bleeding, the use of contrast volume and fluoroscopy time, as well as the JCTO scores between males and females. So in regards to our primary outcome, the results were not significant between males and females for the all-cause in-hospital, as well as the mortality for the longest follow-up. In regards to the secondary outcomes, the procedure success was found to be higher in females as compared to males, but we noted that the contrast volume and the fluoroscopy time, as well as the JCTO time, they were less in females. Like, females had less complicated disease. Probably that's the reason why they needed less contrast volume and less fluoroscopy time. In regards to the other outcomes, the hospital bleeding was more in females. We don't know exactly why, but some of the studies did report that femoral access was used more commonly in females than in males. That's why we were thinking probably that's the reason. And lastly, TVR, which is target vessel revascularization, is the last outcome, and there was no statistical significant difference at the longest follow-up between males and females.
Thank you very much, Dr. Latif. So this meta-analysis was published in late 2021. Earlier this year, we had the manuscript from the ER-CTO registry that was also published in CCI. Dr. Avran, would you please summarize for us the salient features of your study?
Okay, thanks. So the study included 35,000 patients. So in that patients, we have 15% of women, and all the rest is male. It was between 2008 to 2019. And I have checked if in the late years there was some differences between the percentage of women and men, and it's quite comparable. So it seems to be a little bit higher in the very last year. It's going up to 18%, but it's always less than 20%. And what we check also is quite the same that the meta-analysis is that, in fact, the women who underwent CTO procedure seems to be older than men, a little bit more hypertensive or diabetics. And then we also discuss about the localization of the CTO. Is there some differences between the men and women? We know that there is a majority of right coronary CTO occlusion. It's quite the same, male or female, but it's a little bit more LAD for women and less circumflexes for women also. So this is the point. We show also that the women who underwent the CTO procedure have a lower GCTO score, more tapered proximal cap, less length of CTO, and less calcified lesion. We check also the strategy we did for between men and women, and when we can see that we did more integrate CTO procedure for women than men, it means that we don't know. So this is maybe an explanation that we can have, but we don't know if we are maybe afraid to use more retrograde strategy for the woman because of small collaterals or less collaterals feelings between male and woman. And we did also less ADR strategy also. So maybe because the diameter of the vessel is quite lower in the woman than the man. Also, we check, as you did in the meta-analysis, the success rate. And the success rate is higher in the woman than in the man. But I think maybe it's because there is a bias about maybe the selection of the woman cases is quite more severe than that we did with the man, but maybe we will discuss it after. So also about the complication, we have shown also that there is a little bit more bleeding with the woman. So at the puncture point also more hematoma and a little bit more perforation. So that's going with the primary idea of a smaller vessel, maybe more tortuous collaterals, we don't know. So I think this is the summarize of the ERCTO paper.
Thank you, Dr. Aaron. I think both these papers, albeit comprising of observational registry data, are encouraging in that CTO-PCI in women is feasible and safe. And the common factor that we see across both of them is that women were older, greater comorbidities, but less complex CTO lesions. And in ERCTO, we also saw lower JCTO scores and indications of other more favorable CTO lesion characteristics that might be amenable to PCI. So to what extent do we think these could have contributed to the better procedural success rates in women? Dr. 𝔻𝕚𝕚𝕚, we could have you first.
Yeah, so I think that was a great summary by both Aska and Dr. Aris. So I think that, women usually tend to present late, and then they also tend to have less referral to PCI or CABG in general as we normally see. And so I suspect that having the complex disease would have tended these women to be treated medically, and those who had less complex disease probably were selected to have a PCI, and both the studies show that the women have lower JCTO scores. And then looking at the ERCTO trial, women had more antegrade, and true was more successful in these procedures, and so that kind of supports the fact that these patients were less complex lesions, and the success was higher. So I think that probably contributed to a selection. The selection bias probably resulted in a higher success rate in women as opposed to actually being a better procedure in women. Does that answer the question?
Yes, I think that it does. And in fact, Dr. Aaron also touched upon this issue of selection bias, and how would either of you say what would we do to mitigate this, and especially in terms of interpreting the results of these studies?
Yeah, so I think we have this huge problem of underrepresentation of women, right? I think probably having clinical trials that are just specific to women, which may be harder to do because we may not have the numbers of patients, or the enrollment may take longer. But I think just having trials focused and specific to women may overcome this issue. The second thing is to raise awareness among both physicians and women, female patients, right? To explain to female patients what symptoms are, when they should report these symptoms, and such, so that they're able to present sooner or be more willing to participate in a clinical trial if they feel like they have these symptoms. And then physicians too, to show them that women do have disease, and even if they have complex disease, probably it's something that they should think about before referring to medical therapy versus PCI, or kind of sort of doing an all-comers trial where all patients with CTOs, instead of just selecting those with a lower JCTO score, may be another way of including all the women who may be candidates for CTO PCI, or who meet the criteria for CTO PCI. So I think these may help in actually having more women in these trials, and being able to see an all-comers.
Thank you, Dr. 𝔻𝕚𝕚𝕬𝕠𝕕𝕖𝕠. Those are really very great and valid points. If I could go back to the paper, your paper, Dr. Aaron, although in both papers we found that women had better procedural success, and also in the RCTO analysis, in your paper, you also mentioned that women had higher rates of procedural complications, more perforations, vascular complications, and also bleeding. How would you explain these findings in women, despite the fact that they had greater rates of CTO recanalization success?
So my explanation is, I think that we shown that the diameter of the vessel are lower in women than men. So we know that it's more difficult to join the distal cap if the distal landing zone has a lower diameter than a bigger one. So it could be also one explanation. The second explanation might be that the coronary arteries, like the femoral arteries, may be more fragile in the woman, and also because maybe we treat older patients in the woman group than the men group. So it could be, I think, some of the medley of all these point could explain that there is quite a little bit more, but significantly more complication, periprocedural complication. But
yeah, that point to add to that is that estrogen is usually protective in women, and in either in menopausal or postmenopausal, because
absolutely.
Estrogen level falls, then the arteriogenesis, it has a negative impact on the arteriogenesis. So they have smaller collaterals, as reported in several other papers. So that may be another reason why, we haven't seen that very many retrograde procedures in women, as we see with men who have better collateral flow.
And it would be interesting as well to know if the prevalence of rheumatologic disorders as the etiology for the coronary artery disease is different between men and women, and whether or not there would be more negative remodeling as opposed to positive remodeling in the proximal versus distal vessels for women as opposed to men that might contribute to it. Because it is interesting, despite the lower JCTO score, in a very large number of patients, this difference in perforation rate.
Absolutely. I think these are all very valid and possible explanations contributing to this higher complication rate. Another aspect was that, of course, we touched a bit about the low numbers enrolled. So proportions of women across both papers was about just over 15% in ERCTO, about 25% across all the studies in the meta-analysis. So given this rather large underrepresentation, do we think these numbers are enough to draw meaningful conclusions from the findings of these studies? Dr. Avran, if you could go first.
Yes. So finally, the question is that differences between men and women is due to underrepresented from the woman, or are they undertreated? And this is the main question that we have to answer. In my personal data, I really make no differences between men and women. But when I check my data from this 10 last year, it's a fact that I'm treating 60%, 70% of male and 30% of women. So, and there is no selection from my side. So it's also a point. I think for me, this is the question we have to answer. This is just supposition for my paper.
I guess
so I don't know
also
what the meta-analysis can tell us about the question. Maybe you have more analysis, or it's the same.
Dr. 𝕚𝕚𝕚𝕚𝕚, would you add to? I'm sure there's no doubt about the fact that there's perhaps less of a selection bias, but maybe the issue here is a referral bias, so that all the patients that are actually referred to the interventional cardiologist, perhaps the bias starts even before the interventional procedure begins. Is there anything you would like to add, Dr. 𝕚𝕚𝕚𝕚𝕚?
Yeah, I think obviously having 15 or 20% women in these trials, and then going off these results and applying those results back to female patients does not seem to be like the best way of applying trial results. For sure, as Dr. Avran mentioned, there's underrepresentation and there's also the selection bias. But I just don't know how best we can answer the question of how to know even if women have disease or not. Are we supposed to maybe go back into the entire general population, go back and look at all these films and see how bad the disease is in women and whether they're being treated or not? That probably maybe a larger scale than just having a specific referred CTO group of patients to see if there's more women that are not being treated despite having CTOs. So I think it's a larger question that I think a bigger scale general population trial may be able to answer, that is specific to women.
But it would really, I think, interesting to check. Maybe we would have the same number if we check only the PCI, not the CTO PCI. But if you check the PCI in general, there is less women in the cath lab than men.
I think that's a very relevant point. But
yes,
please.
And I don't think that it's because the women are not going so much to see the cardiologists or the physicians. Maybe there is hormonal protection from the before the menopause, but after, I don't know.
That's a question that will remain unanswered, but suffice to say that we do have an underrepresentation problem, and I suppose we have discussed the challenges to it and potential strategies to mitigate it as well. Dr. 𝔻𝕚𝕚, would you have any concluding remarks?
So first of all, thank you to our submitting authors on these two very important manuscripts for participating in our webcast this morning. I think that, there are clear messages that come from both the meta-analysis and the multi-center registry. And that is that, one, women can be treated successfully with percutaneous techniques to treat CTOs. Two, it is unlikely that there is a fundamental difference in the prevalence of chronic total occlusions in women to account for an 85% versus 15% presentation in these two very important CTO manuscripts. And that leads to the importance of, I think, several initiatives. One is to understand symptom presentation in women versus men with CTOs. Two, further insights to better understand the anatomy and collaterals to determine whether or not there is a true bias in how we as interventionalists approach it, or are there true anatomic differences that lead us to avoid more complex anatomy in women? I don't know the answer to that, and that is unlikely to be informed by randomized clinical trials. And this is where the role of observational studies and registries are so important to inform us on how we take evidence and apply it to our individual patients. And so I think that these two manuscripts have shed light on important issues and provided a path forward for further scholarship to help enlighten and make certain that our women are being approached in similar ways than men, and that we better understand the unique, potential unique attributes from a symptom perspective, anatomy perspective, so that we better understand what I think is the signal here. There may be a difference in safety in how we apply procedures that have been done predominantly men to women, and that may better inform us as how to mitigate the risk of bleeding and perforation moving forward.
Thank you very much for that remarkable wrap-up of these studies findings, Dr. 𝔻𝕚𝕚. So I think we had a very insightful discussion, and we can conclude here. Thank you very much to our esteemed panelists and authors for their submissions, and also for taking the time with your insights today. Thank you.
Have a beautiful day, everybody.
Thank you so much.